So as we know, there's increased awareness of the utility of continuous EEG in the ICU setting. Um, how do you reconcile that with the increased cost of that process, which in terms of the cost of the equipment and the cost for the personnel, which is involved in that?
I think there are several indications for continuous EEG, one of which I'd say is incontrovertible. The patient who remains in electrical status after the initial treatment of convulsive status cannot be managed any other way. So the equipment and the technical support needs to be available at least to be able to manage those patients. The discovery of non-convulsive status in a patient with another severe neurologic disorder is another indication that many of us feel is an important reason to do the continuous EEG recording, although there certainly is not a consensus on both what the treatment should be and what the outcome of the treatment is. Moving on to non-epileptic disorders in which EEG is useful, monitoring of patients who have subarachnoid hemorrhage to try to predict vasospasm and hopefully abort it from becoming clinically apparent vasospasm is another one in which the EEG has been demonstrated to be useful. But in that situation in particular, we don't have evidence comparing its expense to that of transcranial Doppler or some other technique for trying to establish the presence of spasm before the patient becomes symptomatic. When I was asked to give this presentation, I was, of course, aware that the literature was not going to be very useful in terms of any economic analysis. So we undertook our own economic analysis within our institution and determined that over the last fiscal year, the collections that the institution allocated to the continuous EEG program meant that for each day, for each patient, the institution made $280. So from the standpoint of the institution and the interpreters, they're not losing money doing this sort of process. Whether this is a good use of institutional resources in terms of purchasing more equipment and hiring more technologists, of course, can't be answered by these data and would need a much larger study. We also looked at ways in which one could potentially test the utility in terms of patient outcomes of doing some of these monitoring procedures. Of course, as a diagnostic test, one can't do a double-blind randomized trial of a diagnostic procedure. The appropriate comparison would be against some other gold standard, but since EEG is the gold standard for epilepsy, then there isn't at this point another test one could compare it to. In the area of subarachnoid hemorrhage, though, one could do a comparison of the ability to detect vasospasm early by doing something like alpha-delta ratio monitoring compared to transcranial Doppler. And in both areas, one could envision an outcome study in which the EEG results are applied in different therapeutic milieu so that you have choice of two different drugs for the treatment of refractory status or two different treatment approaches in subarachnoid hemorrhage and apply the diagnostic technique to see whether those therapies make a difference in an area where you couldn't make those decisions without the EEG. But these are studies that are as yet not funded, so I don't have any answers for them.